As you can see from your programs, we're going to talk about first breast, emergency general surgery, minimally invasive robotics, and community surgery. And we've got people who are going to help us in each of those things. I'm going to start, because on my program, with Dr. Colleen Murphy from the University of Colorado, who is a breast surgeon and is going to talk to she's going to speak better than I will, talk to us about top papers in breast surgery. So round of applause, please.
Well, thank you again for sticking around for this last session, and thank you for inviting me to give this presentation. So I'm going to talk about top papers. I'm going to call this breast oncology because as those of us who practice in oncology these days know, a lot is happening not just in surgery, but also in our other disciplines we collaborate with so closely. I have no disclosures. So I have 4 papers I want to briefly discuss with you. 2 of them I really think are practice changing. So when you leave this room today, hopefully you'll keep these in mind as you see these patients. And the other 2 are kind of on the pathway to becoming practice changing probably within the first 5 years. So the first paper I'm going to talk to you about, I believe is practice changing. This is the TAM-01 study, and we have nicknamed it in the field the baby TAM study. So the title of this study is a randomized placebo-controlled trial of low-dose tamoxifen to prevent recurrence in breast non-invasive neoplasia. And this is the 10-year follow-up of this study. So what's the point of this study? So the point of this study was in women who are either treated for DCIS or high-risk lesions like atypical ductal hyperplasia or lobular carcinoma in situ. The longstanding recommendation for these patients is to recommend some sort of hormone blocking medication. If anyone works with these patients, we know nobody likes to take their hormone blocking medication, especially for risk reduction. And so this trial has really asked the question, can we have equal efficacy with hormone blocking medication for these groups of women, but potentially lessen the side effects by giving a smaller dose of these medications. So specifically the drug that was looked at in this study was tamoxifen, the drug we can use for pre and postmenopausal patients in these circumstances. And instead of giving the traditional 20 milligram dose for these patients for 5 years, we were giving 5 milligrams for 3 years, so a pretty significant dose reduction. In my practice, I use 10 milligrams to treat breast pain, and I feel like I don't see a lot of side effects anecdotally, and so this is even a smaller dose than that. So how this study was put together, it was 500 women who had excised ADH, LCIS, and DCIS. DCIS was the main group of patients in this trial. These DCIS patients, most of them did get radiation as well. This was a nicely put together randomized control trial. We compared low dose tamoxifen to placebo. They didn't do the head-to-head comparison of the 5 to 20 milligram doses because that would take a lot more patients, but this is a pretty good surrogate in my opinion. And this trial ran from November 2008 to March of 2015. So here is a schematic of the results. So we started with 500 eligible patients. Half of them took that 5 milligram dose of tamoxifen for 3 years. The other half got a placebo. And when we look at the number of breast cancers that developed in these groups, we see the placebo group had 41 breast cancers and our tamoxifen group had 25 breast cancers. And this was a median follow-up of 9.7 years. And this was significant. So the annual rate for women taking this tamoxifen developing breast cancer was 11.3 compared to 19.5 in our placebo group. And when you look at our curves, we've got 2 curves here. On panel A, we just see the cumulative incidence of breast cancer incidence in our groups. And yes, it's statistically significant that baby TAM group does better and has less events. Panel B shows you what is the risk of developing a contralateral breast cancer. So really a reduction in future events in the contralateral breast. And that was statistically significant as well in our baby TAM group. Well, what about adverse events? So it was not a primary endpoint to look at hot flashes, which is our most common issue with putting patients on these drugs. But we did look at the traditional adverse events we see with tamoxifen. Probably most concerning to most folks is DVT. We don't see a difference in adverse events in either of these groups. And they did do a subset analysis to look at hot flashes. So in general, women taking tamoxifen compared to women not taking tamoxifen, the tamoxifen group, this baby TAM dose had a 1.5 higher risk or more hot flashes per day, which accounts for about 1 hot flash per day for these groups of women instead of women not taking these drugs. In general, women who take the 20 milligram dose of tamoxifen have twice the amount of hot flashes. So a little bit more hot flashes, but definitely better than our traditional dose. So this study concluded that in women with excised DCIS, ADH, or LCIS, that 5 milligram dose of tamoxifen or a baby TAM dose for only 3 years significantly prevents recurrence from non-invasive breast cancer. And this is durable over time. This is durable for 7 years after treatment cessation. That's one thing I will say. We often wonder if you put patients on these drugs for 5 years, well, and they're only 45 years old, are they going to get that benefit, several years out? And this study certainly suggests that we do have a durable response even after these drugs are discontinued. All right, our next study is the ACOSOG Z11-102 study. So the title of this study is Local Recurrence After Breast Conserving Therapy in Patients with Multiple Ipsilateral Breast Cancer. Dr. Chapkar kind of alluded to this study yesterday. I think this is a practice-changing study as well. So this is a very simple study design. It asks the question, if you have a patient that presents with multiple ipsilateral breast cancers, can you still do lumpectomies? Can you still do breast conserving surgery in these patients? Is it oncologically safe? So this trial looked at 204 women. They had either 2 or 3 foci of biopsy-proven breast cancer. They could have nodal involvement as well. And they underwent multiple lumpectomies. This also was a very nicely designed trial. It was phase 2, single arm prospective trial. And our primary endpoint was just looking for instance of local recurrence. They felt that the recurrence rate that would be acceptable at 5 years is under 8%. And this trial ran from November 2012 to 2016. And the median follow-up for these groups was around 66 months. Just to look a little bit more closely at the enrollment criteria, one of the 2 sites had to be invasive disease. They allowed T1 and T2 tumors, so pretty good sized tumors up to 5 centimeters were included. There had to be at least 2 centimeters between sites. Margins needed to be negative by our typical negative margin criteria, no tumor anchored 2 millimeters for DCIS. Patients did get whole breast radiation with a boost, and endocrine therapy and anti-HER2 therapy was given by the medical oncologist as deemed appropriate. The thing to point out on patient characteristics here is most patients had 2 foci of disease. It's somewhat uncommon to get 3 or more foci in the breast, but for this trial, I think clinicians felt okay with that 2 different sites. And most patients underwent a multi-site lumpectomy instead of getting the tumor out through one incision most people used to. So here's the results. It showed that, with that 8% threshold, which they thought was considered clinically safe for local recurrence rate, in this group, the local recurrence rate at 5 years was 3.1%, so well below that 8% threshold. The unexpected finding when they went down and tried to see if there were any risk factors associated with local recurrence, they actually found that patients who got breast MRI before surgery actually had a lower risk of local recurrence, which is kind of an interesting finding in our field. And then as typically we see, patients who take endocrine therapy have a local recurrence risk that's a little bit lower. So this trial concluded that in patients who have multiple ipsilateral breast cancers, lumpectomy is just fine for these patients. It has a very acceptable low 5-year local recurrence rate. So I would say take that with you too as you leave this room and take care of your patients. All right, so these last 2 trials are talk about a couple different concepts that I think our field is moving towards. So the first is a medical oncology trial, the Destiny B04 trial. So this trial is looking at a new drug called trastuzumab deruxtecan in patients previously treated with HER2-low advanced breast cancer. So let's break down what I'm talking about here before we talk about this trial. So in general, what this trial is trying to look at is kind of one of our newest trastuzumab or trastuzumab Herceptin type drugs. for breast cancer, but specifically this drug is targeting HER2 low breast cancers. And we'll talk about that definition of us in a second. We call this drug TDXD. It's a little bit easier than trastuzumab deruxtecan. And so this was one of the first big trials looking at this drug. So of course, we looked at patients with locally unresected disease or metastatic disease. This is a very nice multi-center phase 3 trial. And it was a randomized trial comparing the safety and efficacy of this TDXT drug to standard chemotherapy in this group of advanced breast cancer patients. And this trial went from 2018 to 2021. So let me just talk to you about this drug. Probably most people are familiar with TDM1, which is also known as Kadcyla. This was kind of the first drug in the modern era for HER2 therapy. And what these drugs are is they're basically antibody drug conjugates. So these are smart bombs. These are really neat drugs. What they are is they basically teamed up our antibody that targets the cancer cells to some kind of typically chemotherapeutic drug. So Kadcyla or TDM1 was the first drug in this class. And basically how these drugs work is they attach to the breast cancer cell and they drop, we call it their payload, which is their drug that's going to get rid of these cells. And the Kadcyla drug, the payload it dropped was a microtubule inhibitor. TDXT, or the trade name is Enhertu, its payload is a topoisomerase 1 inhibitor. So these are super smart drugs that take advantage of all the work that's been done with using antibodies and treating breast cancer cells. Well, what is HER2 low breast cancer? So HER2 low, this is kind of a new term in our world as well. So HER2 low are breast cancers that are on IHC, either HER2 1+ or HER2 2+, and then a negative in situ hybridization study. So these are patients you normally wouldn't think of anti-HER2 therapy for. And as I said, 60% of women who have breast cancer have a HER2 low breast cancer. So it's a large number of patients that we're talking about here. So in this trial, like I said, it was a randomized trial. These patients that were HER2 low, they either got the TDXT drug or they were just given traditional chemotherapy based upon the medical oncologist's choice. So nice randomized trial. And what we see when we look at our curves is that progression-free survival in women who get the TDXT drug is significantly lower. It's or 10.1 months for patients who get the chemotherapy or who get the Enhertu versus 5.4 months who get traditional chemotherapy. And we also see that translates into survival benefit for patients getting the TDXT drug. Well, what about toxicity? How does it compare? Well, as it turns out, patients do better with TDXT. So compared to chemotherapy, we see less grade 3 higher toxicity. The one thing to keep in mind with this specific drug is we do see a little bit more pneumonitis than we would with the chemotherapy group. 12% of those patients got pneumonitis. So this trial concluded that TDXD resulted in significant longer progression-free and overall survival than traditional chemotherapy in women with HER2 low metastatic breast cancer. So there's a spinoff on this trial that we have really early data on. So it's looking at TDXD now in a neoadjuvant setting. And this is actually in patients with hormone positive HER2 low breast cancer. These patients traditionally, you can give the neoadjuvant chemotherapy, but we tend not to see that much of a response in that group of women. So TDXD might actually change that. So keep your eyes out for this drug because I think it's going to make a big difference in our hormone positive HER2 low breast cancers going forward. All right, and the last trial I wanted to review with you is the OPBC-04 study. So this trial was presented in abstract form at San Antonio just a few months ago. We're still waiting for the final paper, but what this trial is looking at is the oncologic outcomes following omission of axillary node dissection in node positive patients downstaging to node negative after neoadjuvant chemotherapy. So what this study is really trying to answer the question is, in those patients who present who are node positive and have go through neoadjuvant chemotherapy, our current practice is to perform a targeted axillary dissection to stage the axilla in those patients. A targeted axillary dissection is a little bit different than a sentinel node biopsy. Most people are probably familiar by now with sentinel node biopsy. Inject a couple dyes in the breast and pull out those lymph nodes. Compared to a targeted axillary dissection, the targeted axillary dissection is simply a sentinel node biopsy plus removing a biopsied lymph node. And usually we have to do some sort of localization procedure to make sure we get that lymph node out. So this is really the first study that's looked at the oncologic outcomes of targeted axillary dissection compared to sentinel node biopsy. So this was a large retrospective trial of 785 women. It was a multi-institutional international trial. And this included a large range of women with T1 to T4 tumors, and up to N3 disease was included. And this study ran from 2013 to 2020. So here are a summary of results. So the follow-up wasn't super long. It was a 3-year follow-up period that we were looking at. So we first looked at the rate of axillary recurrences. And in our two groups, there was no difference between either group. Same thing is true for local regional recurrences, no difference in either group. And finally, invasive recurrences, which they classified is local regional recurrence or systemic recurrence. So even looking at metastatic disease there. And again, there is no difference in either group. So this was a negative study. And they concluded that axillary recurrence after you omit axillary lymph node dissection in these patients, when their axilla has been downstage, that it's very rare. And we've known this for a long time. And it doesn't change local regional recurrence rate. It doesn't change the risk of distant recurrence. So I think this is one more study that shows what we do in the axilla probably doesn't really make a difference. So keep your eyes peeled for that over the next 5 years. I think we're going to continue to get more data that suggests what goes on in the axilla doesn't really make a difference in outcome for these patients. So thank you.
We've got time if anybody has questions. You presented that very well, and HER2 low is a whole new concept for me, I will say. So great. Questions about things that you should be doing? I also neglected in my introduction to mention that Dr. Murphy is a breast surgical oncologist at University of Colorado. You're the medical director of breast surgery.
Yeah, I meant we have multiple satellites. So yes, one of the satellites is.
With a specific interest in young patients with breast cancer and lymphedema, which as you were presenting that last thing, the last paper made me think, because those of us who've been at this for a while and have done our share of axillary node dissections, I don't know if anybody's seen, any of the less experienced surgeons have seen the patients with upper extremity lymphedema and the disabling effects of that. So if we can prevent that, that is great. So thank you so much.
Yep.
We're getting there.
We're getting there. Yep.
Things are changing. So thank you so much. That was awesome, Colleen. Thank you. All right. Next up. All right, here it comes. Dr. Nicholas Sheets was originally from West Virginia, went to school there, went to medical school there, did residency there, then decided to come see what the other part of the country looks like. And Dr. Sheets did a fellowship in acute care surgery in Fresno. So I have a bit of a bias and, other knowledge too. Completed his fellowship and is now in the faculty at UC Riverside. And I think we've seen presentations from a number of the students and residents that he works with. Dr. Sheets is going to talk to us about top papers in emergency general surgery. AV person, could we get a 10-minute timer going? That'd be great. Thank you.
All right. Thank you, Dr. Kalbson. Thank you to the Southwestern Surgical Conference for letting me talk today. And I'd also like to thank everybody here. We did bring a bunch of students and a lot of medical students, and this was their first conference and their first time speaking, and it is very welcoming. So thank you all for that. So I'll present the top papers in emergency general surgery. There's a lot of papers, a lot of really good papers, and it's really hard to choose one. It's quite a daunting task. Do I choose just the top of the stack or the most cited or the most emailed? It's very hard to pick out which papers. I have about 2 to 3 to review and some of the background for some of those. And then flashback, 2019 was my first Southwestern Surgical Congress in Huntington Beach. Dr. Kalbson and I did some surfing lessons. I presented a paper on the splenic capsule and come back, and I've always enjoyed this conference. So there's a lot of topics, I think hot topics in emergency general surgery, diverticulitis, appendicitis, management with that, with antibiotics. I think there's also hernia repair, or we want to put an infected mesh or a mesh in an affected field, whether it be permanent or biologic. And also most recently, the COVID-19 papers that come out with emergency general surgery and how that affected us. And now more recently, AI and how that's going to affect the medical field. I don't have time to talk, we can talk about this forever. I only had to pick two, I think to fit within the time frame. And so I just picked diverticulitis and appendicitis and a little bit curve at the end, just because I want to keep it interesting, not boring, and put everybody to sleep. So some of the background, Dr. Mayo in 1907 first talked about the treatment of diverticulitis, like abscess drainage, diversion, resection. Later, the Rankin and Brown proposed a 3-stage procedure. In 1980s, Hartman presented the 2-stage procedure, became more popular if there's a review and some randomized controlled trials regarding that. And then a few years later, there's the Hinchey classification. And quite, through all my general surgery training, as always, the Hartman's procedure was kind of a gold standard for diverticulitis treatment. And I think now you can't see where I'm going with this. That has kind of changed. And that's what I'm going to review. So the paper I'll talk about is this 2021 paper. It's a follow-up of the Diverti trial. I'll give some of the history here because this paper doesn't come in isolation. This paper comes with a lot of background to it. So the first study, leading up to this was 2012 is an attempted randomized controlled trial that randomized patients to primary anastomosis versus what they call non-restorative surgery, the Hartman's procedure. They had 90 patients, went on for 9 years, and it was cut short because they couldn't get enough patients. But they published their data, and basically it supported their hypothesis that adverse event rates following primary anastomosis was not inferior to those following non-restorative colon resection performed for perforated diverticulitis with peritonitis. So these are our 3s and 4s. And obviously you can think if you have a surgeon and they're looking at the field, they're not going to randomize their patient to a primary anastomosis they felt in their heart. That wasn't the thing to do. I think that was kind of the problem with that study. Also in 2012, a second study from Switzerland randomized patients and looked at primary anastomosis with averting ileostomy versus a Hartman's procedure. They had 62 patients in their study and found that more patients with the primary anastomosis had ileostomy reversal than those with a Hartman's procedure. 90 versus 57% were reversed. And also they had fewer serious complications in hospital days. Third study was in 2017 in France, was a randomized controlled trial of primary anastomosis with averting ileostomy versus Hartman's with the primary endpoint of mortality. Follow-up 18 months, they had 102 patients and found no difference in mortality, but again, a significant difference in stoma reversal. And the fourth study from Belgium, Italy, and the Netherlands was a ladies trial with the primary endpoint of stoma-free survival. They had 113 patients and at 12 months, 94.6% of their primary anastomosis patients were stoma-free, while 71% of the Hartman's patients were stoma-free. And they conclude that primary anastomosis was superior to Hartman's procedure with regards to the 12-month stoma-free survival and overall morbidity after stoma reversal, with no significant difference in short-term morbidity and mortality after the index procedure. Therefore, what they said is in hemodynamically, this is important, hemodynamically stable immunocompetent patients, primary anastomosis is preferable to Hartman's procedure for the treatment of perforated diverticulitis. And all these were Hinchey grade 3s and 4s. Then after this in 2020, there's a couple meta-analyses and reviews that all kind of support the primary anastomosis. And that kind of leads up to this paper. This was 2021 paper, and they had a follow-up of 9.1 years. And they had 102 patients with purulent or feculent peritonitis secondary to diverticulitis. All patients had a laparotomy and they were randomized to primary anastomosis versus Hartman's procedure. The patients were then contacted for follow-up data. When the patient could not be reached, the team then contacted the primary care provider to see if the patient passed away or not. Their baseline characteristics, basically, there's no difference in these two sets of patients. And then one of the things that they looked at was interesting was incisional hernias in the Hartman's procedure group. This also included peristomal hernias, so less so in the primary anastomosis group. And so the outcomes in regards to quality of life, which is what they're mainly measuring, was Physical and mental quality of life was higher among the primary anastomosis group. The authors ultimately conclude that the primary anastomosis for perforated diverticulitis is associated with fewer long-term complications and better quality of life than the Hartmann's procedure. The primary anastomosis significantly reduces the incisional hernia rate and the need for reoperation. And this, this study is just kind of like a conclusion and a full round look now back at what we've been doing with primary anastomosis. So this type of paper is now why the American Society of Colorectal Surgeons states that following resection, the decision to restore bowel continuity should incorporate patient factors such as, are they hemodynamically stable or immunocompetent? Intraoperative factors, one of the things we look at is ischemia, and the surgeon preference. And now this is a strong recommendation. And the Royal Society of Emergency Surgery recommends a Hartmann in critically ill or comorbid patients and suggests a primary anastomosis in stable patients. So why this paper? Click it. All right, click it. Okay. The Southwestern Surgical Congress has a YouTube, which you can watch, and I watched it to see what we did last year. And it's obviously, it was a debate last year. If you can pull up and look at it, the two debating groups on primary anastomosis, even though there's two different sides, they pretty much both conclude that they both push for primary anastomosis. And other reasons why I chose this paper, this is kind of a dogma change from my general surgery training to now. And I think it's really good to look at patient quality of life. I can't name it. Most patients don't prefer a colostomy, especially they have to have one they really want it reversed. And it's especially important if it doesn't affect, what they call mortality or some of these bad outcomes. If you are interested in AI, you can go into Bing and pull up, look for pictures. This is off DALL-E, which is off OpenAI, and I just typed in surgeon and some Greek art. And it just pulls up a lot of interesting things, but on to my next topic. So the next paper I'm going to briefly review is a randomized clinical trial on antibiotic treatment versus surgery for uncomplicated appendicitis and quality of life of the patient. And this will lead into another topic. So they had 186 patients, randomized them to antibiotics or surgery, and followed the patient for 1 year. Then they looked at the recurrence of appendicitis, and for this one also the quality of life at 1 year. They found that 1 year there was a 25% recurrence rate of appendicitis. And this, they did not include patients with an appendicolith. They considered that a complicated appendicitis. And when they looked at the quality of life, it's hard to really see, but at the top, patients who had an appendectomy had a consistently higher quality of life experience than those who did not have an appendectomy. And then the drop right there was those who had to get an full appendectomy. So this is kind of an introduction. The appendectomy versus antibiotic topic persists. Like I looked through when I was looking for top papers, it's like every institution is kind of producing their own stuff, and there's these larger reviews and so forth. And as a surgeon, I love doing appendectomies because I like it because the patients come in sick, they have pain. I do the appendectomy, they immediately feel better, and we can discharge them and usually it's good outcomes. And I like to say because they ultimately concluded that they recommend us doing an appendectomy. Sorry, you can see it. That's kind of the conclusion at the bottom. So let me see. But what if there's like something else different? Has anybody here heard of ERAT? No. So ERAT is this is mostly coming from China. There's actually a randomized controlled trial that I'll review, is where if you have an uncomplicated appendicitis, they go in with a colonoscope, they scoop out the fecalith, or if they saw one on imaging, they irrigate out the appendix, and if the whoever's running the colonoscope feels appropriate, they put a stent in there. Yeah, so this is what gets interesting. I had two safe papers in this paper. This is a 2022 paper from China comparing ERAT to an appendectomy in a randomized controlled trial, the first trial of its type. So patients had to be over 18, have uncomplicated appendicitis, and then the patients were randomized to receive either the appendectomy or ERAT. So here's the baseline characteristic comparisons. There were some differences, the symptoms and signs presented, such as more loss of appetite in the ERAT group, and the appendectomy group had a higher CRP, but basically the same. And here are the outcomes. The appendectomy group had longer operative time, a long hospital stay, and more analgesia. But in the ERAT group, 8 patients, or 14%, had a recurrent appendicitis, and that's in 2 years. So that's less than those who receive antibiotics. And apparently none of the appendectomy patients got appendicitis again. The paper is from China. The authors state, if you do look at the post-operative hold times, they state in their paper that this is kind of their practice. They hold patients who had appendectomy longer, and they were doing the same for the ERAT group. But then halfway through their paper, they realized that these ERAT patients that were getting basic colonoscopy could go home the same day. So what if there's a third treatment that's arising for appendicitis? You have an appendectomy. There's this group saying do antibiotics, but what if you can just do the colonoscope and you have a lower recurrence of appendicitis? And here. And appendicolith is obviously a very significant factor in recurrent appendicitis. I was looking through just to kind of make a point. This paper is just published. About 30%. So what they did is patients who had to get an interval appendectomy, they took the appendix and looked and saw how many had a fecalith. And that one, they had about a 30% recurrence in 6 months. And 70 of those patients who had an appendectomy had a fecalith. So to me, appendicitis is a disease of an obstruction, whether it be from a fecalith or a lymph node, or we had some papers really looking at cancers. But I don't think antibiotics is going to take care of a fecalith. So also you have to think about the patient. A lot of patients, I honestly try to push for more appendectomy because I feel like I can get it done. I get them out of the hospital and don't get a recurrent appendicitis. But some patients, and I understand it. I want to do what's right for the patient. They don't want surgery at all costs. And also, what if your patient's like he's in the middle of playing sports and he has a big game coming up? Or what I know sometimes is I get a patient and they're the sole provider for their family, and they can't take a week off work because nobody else works, and their pay kind of supports everybody, and they need another option that can get them home and get them working, and they don't have to worry about this like heavy lifting or even potential complications. So this could potentially in the future, it's kind of weird, be a future treatment for these patients. So those are my top papers: diverticulitis, primary anastomosis, and then appendicitis therapy. There's a lot of other topics I think we talked about a lot. And I apologize that I probably didn't pull out like a lot of more great papers for emergency general surgery. But to me, I think these are really important and interesting. So thank you.
ERAT. I'm not sure we're going to be having maybe we'll be having a debate about that in a year or two at Southwestern. At Southwest. I don't know. So, all right. Thank you, Dr. Sheets. So we'll we'll move on to minimally invasive and robotics. We are really privileged to have Dr. Jeffrey Chow, who's an associate professor in the Department of Surgery at in Oklahoma. Gee, I had a blank moment there. Training at UT Southwestern, general surgery residency at Northwestern University, and MIS fellowship in British Columbia. He's the director of the OU Health Physicians Tulsa Bariatric Surgery Program, and someone who's got wisdom and experience to share with us. So Dr. Chow, please.
So thank you, Dr. Copps, and thank you to the Southwestern Surgical Congress for the invitation, also the privilege of the podium. So these are my disclosures. This will not be relevant, but I would say probably relevant to this is a majority of my practice is minimally invasive and robotic along with bariatrics. And as my residents will tell you, I'll try to do almost any and everything minimally invasively, which actually includes a lot of endoscopic things that we'll do as well. So with 10 minutes, I do really hope to give everybody a few take homes in these domains. Certainly talk a little bit about robotics, talk about some in the hernia space, talk some about cholecystectomy. We heard a great talk about when to do a subtotal, how should you do one. We're going to talk a little bit at the other end of the spectrum. And then also some things regarding bariatrics that I think for all of us should really be practice changing, both for how we think of bariatrics and also how we think of which patients we should consider for that. So I think we've all seen that there's an increased prevalence of robotics. Across the board, you're vying for robotic time, trying to figure out what things to put on with the robot, but that people are using it for almost anything that you can. But what does the actual data tell us? What are we actually using it for? What's the prevalence in general surgery? So this was actually a study coming out of what would really be the largest health system in the US. So looking at the VA data warehouse, looking at the trends in robotic assisted general surgery over the last few years. And they focus predominantly on cholecystectomy, ventral hernia, inguinal hernia. So really the three of the most common general surgery operations. And the primary thing that they wanted to look at was the trend in the robot utilization. But then a secondary thing was looking at the comparison between open and laparoscopic surgery. And so if you look at this is really the trends of what we've seen. And if you look at 2015, you can see the percentages are barely 1% across the board. If you go and you fast forward to 2019, you can see that all procedures, about an order of magnitude, so went up to about 10% of all of these cases. So still 90% of them are going to, at this time frame, are going to be done open, also being done laparoscopically. When you break it down, the largest increase was actually in ventral hernias. So that was up to almost 14%. So really 9-fold increase. And then also for cholecystectomy up to about 8%. And then inguinal hernias, it was up to about 11. So if you look at it graphically, this is what it looks like as well. So the interesting thing, I think, when you look at them, you can say, well, at the top left, you can see general surgery and that the robotic numbers are actually increasing. If you look at B, it's actually interesting because for cholecystectomy, really almost all of them are being done either laparoscopic or robotic. So we've seen that, even in the VA system, the number of open cholecystectomies is really almost nothing. And then also you can see from ventral hernia at the bottom left, that's probably where there's been the largest increase. And then also you can see for inguinal hernia at the bottom right. And so I think an interesting thing to think about with this is you can rewind. And if you think back to when laparoscopic cholecystectomy began, it was something that people said, well, it's not going to gain traction. Why are you doing this? But now if you actually look, so we still have open hernia repairs. We still have open inguinal hernia repairs. But the one other thing that actually we don't capture in this that as you look at a few years going forward, there are going to be more than a dozen other robotic systems that are going to come forward. And so this is really regionally, you can see around the country where how those changes have been. So you can see really some in the Midwest, the Northeast, and the West Coast are going to be from the heat map, you can see the places that have the largest increase. So when we look at inguinal hernia, so this is actually one of the studies that it was looking at laparoscopic versus robotic outcomes. And so this was actually a very high quality study. So a multi-center patient blinded randomized trial performed from 2016 to 2019, looking at these 6 metrics as their primary outcomes. So they looked at pain, neuropathic pain, wound morbidity, hernia specific recurrence, physical activity, and then hernia related quality of life. And so these were their inclusion criteria. They included patients that were at least 21 years of age, had a primary or recurrent unilateral inguinal hernia. So again, unilateral. So, and with a BMI less than 40. And all of the surgeons in this were ones that had done an MIS fellowship and also had been at least beyond an initial learning curve where they'd had 25 robotic and 25 laparoscopic cases at a minimum. So this is what it looked like for their inclusion. So 113 patients, and after exclusion criteria, they randomized 102. And you can see the initial follow-up where 54 had a laparoscopic approach and 48 had a robotic, and you can see the initial follow-up. So as you fast forward that and you look at how did patients do and with some of the more longer term outcomes is we know that probably up to even 1 in 5 patients with open hernia, we worry that they can have neuropathic pain and they can have chronic pain related to their operation. They had actually pretty reasonable follow-up. I would say better than sometimes it's hard to get a patient from these to follow up at 6 months, because if they're doing well, they don't want to come back. But they had 81% follow-up at 1 year, 75% at 2 years. And they found that there was really no difference between the laparoscopic and the robotic patients from their visual analog scale from a pain standpoint, and then also no neuropathic pain in whether they had the laparoscopic or robotic approach. Pictorially, this is what it looks like. So their pain scores, you can see no difference between, at the left, you can see where their pain scores were initially, but then at 1 year and 2 year, significantly decreased from initially, with really no change between the laparoscopic and the robotic. So the interesting thing is that in this, back to the inclusion criteria, they actually did laparoscopic taps. So, and in this, they actually used metal tackers, which I would say that you probably have other approaches that could even decrease your pain compared to that. But that said, still an improvement with really no difference between the laparoscopic and the robotic outcomes. For the other outcomes, hernia-related quality of life is the same for both groups at 1 and 2 years, along with physical activity. No major wound morbidity, and regarding hernia-related recurrence, they noted 1 hernia recurrence in each group, which was not statistically significant. And again, the take home from that is that lap and robotic inguinal hernia repairs have both have similar long-term outcomes and with experienced surgeons. Not shown on this, that was in some of their prior work, is that actually the operative times and the costs were both a little bit higher for robotics. That said, from the patient outcomes, really no difference. So if we change gears a little bit and talk about laparoscopic cholecystectomy, so I think one of the, as we talk about complications of calculus disease, choledocholithiasis is something that the surgeons have given up largely to GI. I think for many of us, for some places, you'll actually have gastroenterologists that'll be the primary treatment for choledocholithiasis. So I think that this is actually going to be something that's practice changing for anybody who does want to do laparoscopic transcystic common bile duct explorations. So this is actually a study looking at using balloon sphincteroplasty as an adjunct for common bile duct exploration. And so this was actually looking at this institution's initial study with it, using a balloon sphincteroplasty over a 3-year period, and a descriptive analysis of what they did. So if you look at cholangiograms and how you can actually use them, initially, I think in the step-up approach, you can use it just from a diagnostic standpoint. You can give glucagon, and then if you still see a filling defect, you can have a wire and a catheter based, where you can use a Redick-Olson or just a open catheter to flush the cystic duct. That said, one of the challenges with that is that you may still have a higher pressure system from the ampulla. And so in this study, what they would do is, and that what we've actually adopted, is using a wire-based balloon sphincteroplasty to actually efface the sphincter of Oddi. And with that, you can, depending on the patient factors, you can also do a choledocoscopy, or you can actually just flush the stones antegrade into the duodenum. So this, I think, is one of the critical things for it. So if you see this is from part of a cholangiogram, that you can get a wire across into the duodenum, and where the arrow shows you is actually with the balloon being partially across the ampulla. And just like you would do a sphincterotomy, you can do a balloon sphincteroplasty antegrade, which will then actually allow you that you can flush the stones, or it'll allow with a choledocoscope for antegrade clearance, which I would say actually makes these much easier than pulling stones out through the transcystic approach. So in their study, what did they find? They had 28 cases, so a small number, but their clearance rate in this is actually 75%. I can tell you there are actually some other places that there's newer data that with modifications of this probably can have up to above 95% clearance with an antegrade clearance, and along with some of the other adjuncts. These are some of the details about the operative details, and certainly we know that they have a shorter length of stay, and also from this, no postoperative complications. So I think the last thing is hopefully, I hope that many of you in the room have actually seen this, but thanks to Dr. Katari and the group from both ASMBS and IFSO for putting these forward. So these are the newer bariatric recommendations. So if you look, the prior guidelines that we had were from the NIH from 1991. And as most of you may know, those old guidelines were For bariatric surgery, somebody would be a candidate if their BMI was above 40, or if it was above 35 with obesity-related comorbidities. So if we think about that, how many of us use something in our practice that's from 1991? So let's say, would a cardiologist consider a cath indications from 1991, or would you treat a valve like you would from 1991? That's crazy, right? But so for what we had to deal with from an insurance standpoint, 30 years old guidelines that we have newer evidence that that patients benefit from with different criteria. And so as the take home, these are probably broad-based categories of patients who benefit. The reality is, I would say obesity is probably the single biggest health problem facing this country. It's going to be in places like Oklahoma, we're at 40% right now. By 2030, we're going to have 50% of the patients that are candidates for bariatric surgery that benefit from this. The reality is that at the moment, 1% of those patients make it through to surgery, but we have great outcomes in patients that actually have a significant improvement of quality of life and can impact their life quite significantly. But so for the newer guidelines, anybody who has a BMI above 35, without any comorbidities, it doesn't matter, don't have to have any other comorbidities, but with a BMI above 35, you're a candidate. If you have a BMI between 30 and 35 with metabolic disease, or if you're not able to achieve the weight goals that you want. We also know that in some populations, so patients of Asian descent, we know that they develop obesity-related comorbidities at a lower BMI, so their cutoffs are actually lowered. And actually, we're also for adolescents, the pediatric obesity epidemic is only going to be bigger and bigger. I think for many of us, you'll see patients that develop diabetes at an early age of onset, also gallstones and other things that we typically wouldn't see in that population. And those patients actually do very, very well. But you can see the criteria here for the adolescent patients. And also there are a lot of other things that where we think about bariatric surgery as a bridge to help get you to a destination that you want to. So if you have we know that for joint replacements, patients have a worse outcome at a higher BMI, higher rate of infection, less durability of their joint replacement. And also for ventral hernia, I think for all of us in the room, if you have a patient with a large ventral hernia and a loss of domain, or even a primary, hernia and their BMI is 45, what's your durability of that repair if you go and even if you give them the perfect operation, and you're destined to almost in some of those patients above a 50% recurrence and short to medium follow-up. And then also as the last thing for organ transplantation, in particular, I can tell you we see some patients with end-stage renal disease that are too large for transplant because some of the BMI restrictions that they have related to outcomes and with the shortage of organs. We've actually had a lot of patients that have gone from being end-stage renal to then losing weight and then patients that have gotten to have a transplant. So extends their life and gives them much better of an outcome in many ways. So again, thank you for the privilege of the podium, and I'd love to take any questions.
It was educational and provocative.
Now with the new Ozempic and the drugs, which everybody, I think, in LA is on, but how do you think, or how do you work that into your algorithms for surgery?
Yeah, so Ozempic and semaglutides, I think one of the newer agents. The good thing is we're actually going to even have others that are going to have, I think within the next year, some others that'll have FDA approval that are actually even more efficacious. So the challenge is there are shortages. Some patients don't have coverage. I can tell you for a lot of patients, for example, Medicaid won't cover it. So I don't think any state with Medicaid will actually, will cover that. And until there's some generics with a lower price point, I think that it's going to be something where it's a payer specific for that. If somebody's able to get it, I think it's great. We've had patients that have had, 10 to 15% weight loss before surgery. That said, for a lot of the patients that are above a BMI of 40, even if they have that 10% weight loss in a year, you have to stay on that pharmacotherapy long-term. There's a cost to it. And it's not without side effects. You can have bad GI symptoms, so nausea, vomiting. We've haven't had any patients with severe pancreatitis, but that certainly can happen. And at the end of the day, though, I think that for patients that want to come off of it, that want to have a durable outcome, that some of them will end up going to bariatric surgery. As part of our practice, we actually have 2 obesity medicine docs, and all of our patients go through and see them. And so I think what I've actually seen is that it's increased the number of patients that want to get to surgery, because we see people that start at a BMI 40, they start at 45, they get down part of the way, but then they say, hey, I actually want to be much lower. And there's some people that in the end, they don't want to stay on an injectable medication. And so, for example, the patients with diabetes or patients that are on insulin, one of the big drivers for a lot of those patients is they want to come off insulin. And, you know, I think for the bariatric surgeons in the room, I think we'd all be happy to do operations on patients with a BMI of 30 to 35. And, you know, I'd be happy to do 6 of those instead of any day. So thank you.
Thank you. Yeah, provocative. All right. So to sum up, we're also going to have Dr. Joshua Pfeiffer, who's going to talk with us kind of about community surgery related considerations. Dr. Pfeiffer is at Gunderson Health System, bariatric and general surgeon at Gunderson. You're the associate program director, did your training at University of Washington, residency at the University of Illinois, yay, and a fellowship in bariatrics at Gunderson. So without further delay, let's let you have the podium. Thank you.
Thank you very much. And I really appreciate the opportunity to speak here today. The last talk of the last session, the last day, and we're going to talk about community surgery. It's not a lot of clinical information here, but we have hopefully some very thought-provoking and interesting papers to talk about. So I'm a community surgeon, I think. And when I was asked to give this talk, it really made me think about what a community surgeon is. I work in a hospital system that's in La Crosse, Wisconsin. It's about 50,000 people in that city. We have about 300,000 to 400,000 in the area that we kind of serve. And I also teach residents, teach a fellow, run a bariatric department. But I think I am a community surgeon, and I think a lot of us are. And I'd like to poll the few of us that are left here, who in the audience would consider themselves a community surgeon? All right. How about who in the audience would consider themselves an academic surgeon? Okay. Who in the audience practices in rural America? Okay. And how about urban? Suburban? How many out here are fellowship trained? All right, so majority. And these are all questions that went through my mind as to what is a community surgeon. And I thought I'd use a few papers that were very interesting to me to talk about this topic. The honorarium from Medtronic that won't influence this talk. So the who, what, where, when, why, and how of this community surgery to me is very interesting. And why does it even matter? Why are we talking about this at all? Sage's white paper came out a couple of years ago about community surgery, and this has kind of answered a lot of the questions that I had going over it. And they started talking about community surgery as far as where do we work? Okay, so we have 6,200 hospitals in this country and spread out throughout the country, obviously focused in population dense centers. But of these 6,200 hospitals, we have about 1,000 that are teaching hospitals. So when we're training surgeons, the vast majority are going to go out and work in non-teaching hospitals. And I think that's important to remember. And about 120 academic medical centers in this country. So really a very small fraction of the overall hospital force is academic, but well represented at meetings like this, and there's reasons for that. Here's where the AHA plots out the community hospitals around the country. You can kind of see, as expected, fewer hospitals in more rural areas and more hospitals in population dense areas. And so they start talking about community surgery and what it is by comparing it with academic surgery. They said, well, it's hard to define community surgery, but it's very easy to define, or easier to define, academic surgery. And these are the definitions that they talked about in reference to a paper that talked about this. Surgeons that identifies complex clinical problems, ignored or thought unsolvable by others, become an expert in that area. You innovate advanced treatment. You observe your outcomes. You disseminate the knowledge. You ask important questions about how we can do better, and we train surgeons. And I would say a lot of surgeons that are not in academic centers are also doing these things. And so they settled on a definition of a community surgeon as a surgeon who provides care outside of a tenured or tenure tracked academic medicine. Trusted leaders of the healthcare team, focusing on the care of their community. A community practice surgeon includes general surgeons and surgical subspecialists. They are located in rural through urban centers, working in hospitals of various sizes and capabilities. And I thought this was a little broad, but really that means all surgeons are community surgeons unless you're tenured or on track to be tenured. So really, we're just talking about surgeons. Community surgeons, I don't know, we know we need the name community, but certainly all surgeons, or the vast majority of surgeons in this country, would be considered community surgeons. But that community surgeon has changed throughout the years, and there's an evolution of community surgeon, what that means, because traditionally we kind of think of a community surgeon working in a rural area, doing all kinds of things that a very broad practice, right? Vascular surgery, trauma surgery, general surgery, some obstetrics. And that has shifted over time, and we really aren't training surgeons in that way anymore to go out and function like that. And as those surgeons who are still around and very valuable age out, how are we going to replace them? It's going to take 2 or 3 or 4 surgeons to replace that one, to do the thing that one surgeon's doing. The referral patterns, very important historically. You know, if you didn't have these relationships with other providers, how are you going to get your patients? And you're not going to survive in a private practice or solo practice. And then, but one of the benefits was the autonomy. You get to hire your whole office staff, fire whoever you want, and really, that's one of the benefits of that model. And obviously, leadership, and as we've talked about here at this meeting, leadership and your community leadership within your hospitals is very common with both. But I'd say that community surgeons now are more likely to be fellowship trained. There are many different models of employment. Most of us are employed, not private practice or solo practice anymore. We have our referral centers built in, so we don't have to go out and make those connections that we once did. And it's really evolving. The impending problem that we are going to have in this country is that we're going to be about 7,000 surgeons short in 30 years. And this is going to impact rural communities more than urban communities, as we'll talk about in a second. And over the last decade, there's been an increase in fellowship trained surgeons, the majority seeking to practice in the community setting. SAGES looked within itself as an organization or a society, and there's 71% of their members identified as community surgeons, with less than 30% identifying as academic. Yet the members serving on the board and the chairs and co-chairs of their committee were largely academic. And so why is this? Well, urban or rural surgeons and community surgeons are busy. They don't often have protected time to go to meetings. They don't have incentives that academic surgeons have to serve on committees and chair committees, and which is often involved in the tenure track. Rural surgeons are busy because there's not a lot of them. Okay, 20 to 25% of the US population lives in rural America, but only 10% of physician workforce is in that area. If we blow up that map a little bit more, you can see the gray counties here are the ones that are urban. So we kind of ignore those for this purpose, but all the white counties there have no general surgeons in them. And the light green, it's hard to tell exactly, less than or 0 to 4 general surgeons per 100,000 population. So this is the next paper that I came across, the continued urbanization of American surgery and how this is going to become more and more of a problem. This is very interesting. I was pretty shocked that over 100 years, this country has changed dramatically. We were over 50% rural population in 1910. And 1919, which is when this paper was, we're 19.3% rural. So many, many more people living in urban centers. And because of that, urban hospitals are going to need about 5 times as many surgeons as rural hospitals will. We're going to have decreasing patient population in these rural hospitals. And unfortunately, this is going to lead to making it harder to keep these hospitals open. There's driving forces forcing hospital closures in rural America with no population growth, with inefficiencies of scale, adverse effect of low surgical volume. And we are working at that. The American College is working to kind of bolster these rural hospitals, but with only 3% of chief residents wanting a rural practice, it's going to be really hard to train and send out surgeons into these areas. And so the paper proposes that we really change the way we think about how we train residents, and we're going to have to adapt our training to fit the needs of this country. And this is the last paper that I'll talk about here. It's rural surgery training in the United States. A group from, I think, Southern Illinois looked at what we're doing now, what's the current state. And they looked at the different residencies that advertise themselves as being rural or having a rural focus. And there are 39 of them in the country. 12 of them had a broad training of rural surgery. 20 residencies they deemed to be kind of basic training, like a little intro to rural medicine or surgery, and 7 didn't really say what they were doing. So they said they were intermediate. But the table, and it's hard to see on the right, but goes through the different areas that they feel are important to offer a resident who's going to go out and train or practice in rural America. And as we've talked about over and over, 5 years it's hard to train a general surgeon in 5 years anymore and have them come out prepared to operate and do simple, straightforward things that we all would expect to do, let alone adding on OBGYN and urology and orthopedic surgery and thoracic surgery, plastic surgery, interventional radiology. And so their recommendation is that if you have residents who are going to go out and practice in rural communities, that you kind of focus their training and adapt their training to what they're going to need. Not all rural surgeons do C-sections, but a lot of them do. If their community has a good orthopedic surgeon, they're not going to be doing any orthopedic surgery. And so you could take and kind of mold their training to what they're going to need and over the last year. And again, very difficult to do in 5 years, but something is going to have to be done if we're going to train a generation of surgeons that's going to continue to take care of this country. So in conclusion, welcome to the club. I think we're all community surgeons with very few exceptions, especially around the country. The future is uncertain. This is it's going to be a developing problem, and it's going to be very interesting how we adapt to train our surgeons to take care of it. Thank you again for the opportunity.
I'd be very interested to hear commentary or questions. Dr. Albrecht? You're wrapping up. Okay. But the other thing is, as you were talking about this, I mean, one of my other interests is serving underserved areas internationally. And we have a generation of trainees who say, hey, I'm interested in international medicine. And I think broad-based for general surgeons, certainly having broad experience, being able to innovate, to be able to work solely is such an essential skill for that. And I wonder if that's part of it, but that was just very thoughtful and very much appreciated that.
Hi, Vern Miller from Thermopolis, Wyoming. And my feelings are a little hurt. Wyoming is a small place, but my county is white, and I've been there 45 years. So
I know.
I thought I don't even exist.
That's just plain disrespectful. And we
Darn
apologize
disrespectful.
on behalf of whoever put that map together.
And I have a new young partner, and she has decided she's not going to hate me forever for making her do tonsillectomies. But it was certainly a problem. It continues to be a problem. I know the college talks about it a lot. It's really difficult, and I don't see much in the future for training. So I'd certainly be interested in anything that comes up that can replace, old farts like me.
I think that what you're doing is going to be necessary, because 5 years of training and going out and operating by yourself is probably not safe. And you're not going to have the volume to really build skills. But if you have someone senior helping you do things and help mentor you through those first 5-10 years, then there are surgeons that are going to be able to thrive in that setting. And those people are super important. Thank you.
very much. All right. Applause for all the papers, and Dr. Albrecht has the floor. Oh, Dr. White has the floor.
I think I'm the one that's it's my honor to adjourn the 74th Annual Southwest Surgical Congress meeting, and a special round of applause for Dr. Kalps for a terrific program. With that, and without further ado, safe travels home. We'll see you in New Mexico. Okay.